Good afternoon, everyone. I'm Christy Koenig, the EMS Medical Director for the County of San Diego. Thank you so much for joining us for the next lecture in our series of evidence-based medicine presentations. Today's topic is Key Controversies in Pre-Hospital Cardiac Arrest Management. What is the evidence? I will be your moderator, and we will discuss the evidence for and against 3 interventions used for patients in cardiac arrest. Each presenter will have about 15 minutes to make the case. At the conclusion of the 3 presentations, we'll open it up for discussion. The first topic will be naloxone in cardiac arrest, presented by Dr. Veer Vithalani. Next, we will hear from Dr. Saul Levine on epinephrine in cardiac arrest. And finally, we've invited Dr. Lieutenant Colleen Franconi, an emergency medicine resident at the Naval Medical Center, San Diego. Thank you for your service, to discuss mechanical compression devices. Of note, this topic will also be discussed 3 weeks from today at the state quarterly MDAC meeting, so it's a very hot topic. Without further ado, I'll turn it over to Dr. Vithalani to get us started, and then we'll move through the other 2 presentations before opening it up for a group Q&A. And also feel free to place your comments and questions into the chat as we move along, and we'll capture those at the end. Dr. V, the podium is yours.
Thanks, Dr. Koenig. All right, appreciate everyone for being here, and happy to be the first of this somewhat, hopefully controversial on purpose kind of talk about the use of naloxone in cardiac arrest. So here's what we'll cover today. We'll do a little bit of background just to set the stage for opioids and obviously the use of naloxone in general. We'll cover sort of the recommendations that are out there, as well as some emerging literature over the past couple of years that has been done to really hone in on this topic. And then we'll end with sort of some upcoming recommendations that are out there, and then I look forward to the questions and commentary. So as hopefully most of you are familiar, the opioid system is made up of 4 different opioid receptors. There's the mu, the kappa, and the delta receptor, and then there's also a nociceptin opioid receptor that I think we talk less about. Primarily, we focus on the mu opioid receptor. That is where drugs like morphine and heroin act, and antagonist agents like naloxone or naltrexone tend to inhibit both the mu and the kappa receptors, and those are the ones that we typically focus on, because a lot of the sort of analgesic and euphoric effects of opioid drugs and subsequently the reversal agents work sort of on that mu receptor. And so here, as you can see, across the opioid receptors, it's not just in the in the brain that you have these receptors for analgesia. You also have effects on the lungs in terms of, or not the lungs, but you have effects on respiratory depression. You have effects on the pupils with miosis. You get a euphoric feeling, reduced gastrointestinal motility. I'm sure many of people have seen, if not experienced, the psychotomimetic effects, etc., associated that sort of come along with the analgesia from these receptors. And so as we talk about reversible agents, naloxone is probably the most common one that is used both in the emergency department and pre-hospital space. Most of us in the ED are familiar with the injectable formulation, as you see on the right. Comes in varying doses and is typically drawn up and administered either intravenously or nowadays intranasally. There's also the now, I guess, rebranded Narcan nasal spray, sort of pre-filled nasal spray atomizer, as you see on the left, that is sold over the counter essentially now. That comes only in a 4 milligram formulation. And then there is now actually also a auto-injector of naloxone as well, as you can see there in the middle. And these are all used for cases of opioid overdose or suspected opioid overdose, especially with respiratory depression. Another common opioid antagonist that we don't talk about as much is naltrexone. Now, naltrexone can be used alone for the purposes of longer blockade of the opioid receptors. It's also used commonly in tablet formation as a treatment for alcohol use disorder, as well as other use disorders, other drug use disorders, including opioid use disorder. And then it is occasionally combined with other medications for essentially its effects on cravings, for lack of a better term, taking the sort of psychological concept that some of the use disorders, a portion of that is due to the inherent cravings associated with it neurologically. Naltrexone is mixed with other medications, as you can see there on the right, bupropion, which is used as a weight loss medication in the form of Contrave, and is used to really aim at minimizing sort of food cravings. And so when we talk about opioid-induced cardiac arrest, I think for the most part, we consider the fact that opioids have primarily, in overdose, a respiratory suppression that is the sort of initial concerning factor when it comes to overdose. That respiratory suppression, lack of airway reflexes due to sedation, etc., leads to hypoxia. That hypoxia tends to lead into the bradycardia, and the bradycardia results in the cardiac arrest. It is not necessarily as much of a direct myocardial suppressant as it is, as other agents, but opioids tend to cause cardiac arrest not directly, but essentially indirectly through their effects on your respiratory drive and your ability to tolerate your airway and airway secretions. And so surely the sort of pathophysiologic reversal of this is that if you were to find a patient in an opioid-induced cardiac arrest, if you performed high-quality CPR and effective bag valve mask ventilation, you would be able to reverse the issues we talked about. If you were to reverse the hypoxia, which would reverse the bradycardia, and if you improved their respiratory depression, or at least ventilated for them, then you might be able to reverse the issue at hand. But ultimately, we talk the question essentially comes up is, does naloxone administration in these instances have some additional effect on ROSC survival and the ultimate outcome measure of neurologically intact survival? And so this is not a new question. This has been evaluated for years and years by the AHA and others. And if you look at the currently published guidelines from the AHA in terms of BLS and ACLS guidelines, which put out an opioid-specific special considerations update most recently in 2023, it essentially goes on to say that for patients with known or suspected to be in cardiac arrest, in the absence of a proven benefit from the use of naloxone, standard resuscitative measures should take priority over naloxone administration with a focus on high-quality CPR plus ventilation. And so whereas they don't necessarily prohibit the use of naloxone or go out of their way to say you shouldn't use it, they essentially say that there is an absence of proven benefit, and as such, you should focus primarily on the mainstays of cardiac arrest care, such as high-quality CPR. So as many of you are aware, we have in the county protocol a explicit prohibition against the use of naloxone in patients in cardiac arrest, using the same sort of philosophy that we've just described. But since this update, we've had a handful of studies that have come out that I think it's important for us to go over, and what I'm going to cover today are 4 or 5 studies that were published in sort of 23 to 24 that aimed their best at sort of in the best way possible to evaluate the question of, is there some sort of benefit of administering naloxone in these cases? And I think it's important to start with the fact that, when it comes to evaluation of, let's say, new or suspected benefit in cardiac arrest patients, there's essentially 2 real main ways to evaluate it. The first ideal way would be to do a double-blinded randomized clinical trial, which in the setting of cardiac arrest would require a exclusion from informed consent process, which is, for lack of a better term, difficult or cumbersome, but is not impossible, and is how we do a lot of the cardiac arrest research. Alternatively, there is the observational methodologies where you go back and look at cases that were sort of fall in the 2 buckets you're looking at, and try your best to eliminate as many variables as possible, but understanding that it is a retrospective study versus a prospective study. And so the first study I want to talk about was done in 2023 up in the Seattle region, and this was, again, a retrospective study across that region. They looked at over 6,000 non-traumatic cardiac arrests, out-of-hospital cardiac arrests, and they actually did sort of manual review of all of these, looking for essentially a documentation that pointed them towards some sort of overdose related etiology. And that wasn't necessarily just opioid overdose. It was all overdoses, especially opioids, stimulants, mixed overdoses, etc. And the purpose of this study was really just to describe the fact that when they compared their overdose suspected patients versus their non-overdose suspected patients, there was at baseline no real survival difference between the two groups. And so this is sort of the standard that we're working with, which is that if you treat them all the same, you will get relatively the same outcome. Now, you can interpret that how you will, but they went out of their way to really find as best possible the sort of overdose related patients and look at their outcomes, and that's what they found. One interesting thing to note, and something that we'll talk about later on, is that there was a good proportion of these patients that were opioid plus stimulant overdoses, some sort of mixed picture, and that mixed picture group actually had lower survival overall across the entire group, especially even within the overdose population. The next study was done in the New Jersey region here in 2024. Again, a relatively smaller study, but a retrospective single agency study. They looked at 159 non-traumatic out-of-hospital cardiac arrest. And what they essentially did was some cohort matching. So whereas they had slightly more patients that had received naloxone in non-traumatic out-of-hospital cardiac arrest, they tried to find essentially matching patients, and there's some very fancy statistical methods that I am neither qualified nor ready to speak about today, but they essentially look for matched patients, so similar age, gender, comorbid conditions, location, etc., to try and evaluate whether there is a difference between the outcomes in those patients that received naloxone and those that didn't. And so the one thing that they noticed across their population of patients that did receive naloxone is that they tended to be younger, they tended to be male with a white race and less comorbid conditions than the ones that did not receive naloxone. But for their population, of which 23% of their out-of-hospital cardiac arrests had received naloxone, there was no difference in ROSC survival or neurologically intact survival. So again, relatively smaller study, but not showing any survival difference for a system that essentially left it to clinical judgment on behalf of the paramedic as to whether or not the patient should receive naloxone in that clinical care. Strong published a larger study in 2024, again, a retrospective study of about 1,800 cases. This one looked at something, again, another sort of slice of the pie. They looked at arrests that were only before EMS arrival, not something that was evaluated or delineated in some of these other studies, only at non-shockable rhythms, with the expectation that opioid-induced cardiac arrest would not have a shockable rhythm. And they specifically looked at out-of-hospital cardiac arrests in that subgroup who received naloxone before intravenous or intraosseous access was administered. So again, they're looking really at these patients who they suspect that their primary issue is opioid overdose, and before any other standard cardiac arrest intervention like epinephrine, etc., they received naloxone. And some of those were by law enforcement, for example, some of them by medical first response, and some by EMS. Out of their 1,800 cases, it was really a very small minority that met this population, or that this criteria. It was 57, or about 3%, that received this early naloxone. They tended to also be younger and had a lower rate of being a witnessed cardiac arrest. But they found that in this small naloxone subgroup, they had better survival when it comes to ROSC, initial ROSC, survival to hospital discharge, and CPC score, or neurologically intact survival. Again, we'll get to one point in a little bit. And then the last study, which is probably the largest and biggest and sort of most currently talked about study, is the Dillon study from 2024. They looked at about 8,000 out-of-hospital cardiac arrests over really an 8-year period, and had about 700 or so that were believed to be drug-related. Interestingly, despite the 700 or so, there was 1,100 patients that received naloxone. This group did, again, some very impressively statistical analysis to try and do some propensity matching to try and identify patients that existed across both groups that were likely to have, or should likely be, as close to sort of equivalent for a control as possible. They found an increase in ROSC rates and increased survival to discharge, but did not talk much about the neurologic status of those discharged patients. And one thing that we note in both this study and the study before is that whereas in this study, there wasn't really a clear documentation of when the treatment was administered, it starts to raise the question, when you add it to the last study, that, going back to my sort of pathophys of this, when you have a patient who goes from respiratory depression to respiratory arrest into bradycardia and cardiac arrest, there is a spectrum there. It is not a clearly delineated lines between full cardiac arrest and a patient in, let's say, severe bradycardia with respiratory arrest. And so maybe there is something to this thought process that if you have a patient who is respiratory depressed but is not fully in cardiac arrest, that maybe there is some benefit there, much the way that there might be benefit to reversing it in patients who are have a strong pulse, for example, and are just not breathing. So the reverse side of all of this, and not something that's evaluated as much in the literature, is, well, what are the downsides of giving naloxone? Obviously, there are trade-offs to every sort of intervention that's done. I think the one that we talk about a lot is, just at its most basic, the opportunity cost of administering naloxone. If you are focused on preparing and administering any medication, whether it is naloxone or amiodarone or epinephrine or anything else, that is a task and a mental burden that has to be focused on that task as opposed to on anything else. I would always posit to everyone that I would love to see the number of cases that we run in any system that are run exactly perfectly to the book of ACLS, with epinephrine every 3 to 5 minutes, with rhythm checks every 2 minutes, with good end-tidal CO2, etc., to be able to say that there is no opportunity cost to this medication. But I don't know that any system is really doing things that perfectly to be able to argue that. There's well-documented evidence that there is pulmonary edema that is resultant from administration of naloxone in the setting of cardiac arrest, or I'm sorry, in the setting of opioid overdoses, regardless of whether they're in cardiac arrest. There's a lot of philosophies or theories onto why that occurs. But there is a direct correlation between administration of naloxone and resultant pulmonary edema, and best estimate I can get is in about the 1% incidence range. Obviously, as I mentioned before, there is commonly co-ingestants with opioid overdoses. So whether that are stimulants such as methamphetamines or cocaine, even other sort of mental suppressants such as alcohol or benzodiazepines or antidepressants, etc., you can oftentimes have a co-ingestant that would not be reversed by the naloxone, and you could have, for example, unopposed alpha effects or continued sedation when you mix the fact that opioid withdrawal symptoms oftentimes result with, let's say, nausea, vomiting, diarrhea, other upper respiratory secretions, in addition to pulmonary edema. You can put yourself in a slightly worse situation trying to manage those patients. And then there's some very basic science sort of animal studies that show that maybe in the setting of cardiac ischemia, there's actually some cardiac and neuroprotection that opioids provide. And not that this is a solid argument for the use against this, but it's interesting to note, if you delve into the literature, that there's some information out there that maybe opioids protect the heart and brain in the setting of ischemia, and using naloxone does reverse that. And so, as Dr. Khan put in the chat earlier, but ILCOR, the International Liaison Committee on Resuscitation, who do phenomenal work evaluating the literature for specific clinical questions that are out there, is currently in an open comment period for specific items. And one of them, very helpfully for me, was opioid-specific advanced life support therapies for cardiac arrest. They actually did a critical appraisal of all of the literature available current to date, including the ones that were just published this year. And the summary of their treatment recommendations, which I would agree with, are that during ALS or cardiac arrest due to opioid poisoning, there's not sufficient evidence to recommend any additional opioid-specific therapy, such as naloxone, beyond standard resuscitation care. If you are unsure if the patient is actually in cardiac arrest, if you feel a weak pulse, if you only have severe bradypnea but you have a good pulse, then there is likely some benefit to administering naloxone because that patient is not yet in cardiac arrest. But with that, I am happy to answer any questions, and I can share these references when you receive the slides. So
Thank you, Dr. Vithalani. We're actually going to move right into Dr. Levine's presentation on epinephrine. And if people are thinking of questions right now, please feel free to put them in the chat or hold them till the end of the three presentations. Thank you.
Greetings. Is this sharing correctly?
Yes.
Thank you. I was excited to see this topic. This has been of some interest and curiosity to me over time. And I'll tell you upfront what I intend to say later as well with the bottom line, which is, and I'm glad, Veer, that you pointed out that these categories of outcomes of ROSC, survival, and neurologically intact survival, because the data gets muddy, particularly with epinephrine. But epinephrine does improve the rates of ROSC. It does not improve the rates of survival to hospital discharge or improve neurologic recovery. And with that idea, it would make one question whether there is any benefit to ever give it. If you're just getting ROSC and brain damaged patients and no meaningful neurologic recovery, it should draw into question. However, I think, as I'll get into, if it does exist, is with early administration in non-shockable patients. And in fact, and I'm going to keep coming back to this again and again, which is that defibrillation is favored over epinephrine. In other words, if the patient has VFib or VTAC, you should actually avoid epinephrine. And I think that's something that was surprising for me to see in even the USA guidelines, that I don't think we have a keen eye on that in our county protocols historically. There are only two out-of-hospital therapies. Everybody knows this, I believe: prompt chest compressions and early defibrillation. And a whole bunch of things have been studied aggressively and have not shown benefit, including high-dose epinephrine, high-dose norepinephrine, antidysrhythmics, sodium bicarbonate, calcium, steroids, fibrinolytics, magnesium vasopressin, atropine, and beta blockers as well. And just to get this issue out of the way, this is the study that I think most people relied on in the early 90s to say that there's harm in high-dose epi. Really kind of shockingly, I think this was before my time in medicine, but I did hear about high-dose epi, and I didn't realize it was like, 10 to 15 milligram doses at a time. These patients were generally had an increase in survival to discharge slightly, but no improvement, and some evidence towards harm in the high-dose epi group. And so that really has fallen out of favor for a few decades now. I like to think about epinephrine as sort of like a Hail Mary. In football, if you throw a Hail Mary and you don't win, it doesn't mean that the Hail Mary makes you lose, but you can slice and dice the data such that you can say something like 65% of patients in cardiac arrest that don't get epi survive. And if you have over 7 doses, it's less than, 0.1% survival, 0.002% in the very high range of doses. Nonetheless, I'll move on to talk about the molecule of epinephrine. It was extracted first in 1895. It is a hormone and a neurotransmitter, and it's really, I think, most helpful for me at the end of this to think of adrenaline as a potent vasopressor more than anything else. The early studies for its use were from a dog asphyxiation model. And then 99 years later, the appropriate use of administration was put forth by Mr. Tarantino. The US guidelines are based on the AHA. And the 2020 guideline has some basic statements that we expect another update in 2025 from the AHA. But this is really what all our guidelines are based on. for a variety of things, and particularly including ACLS. Their conclusion is it's appropriate to administer epinephrine for patients with cardiac arrest. They don't put a ceiling on it, it just says every 3 to 5 minutes. They recommend against using high-dose epinephrine. They recommend against using vasopressin, which had been of some fanfare recently, or well, 10 years ago. And interestingly, they really do point out that IV is favored over IO. And that's something that comes up with the other international bodies, which I'll get into later as well. But if you look at more detail of the AHA, that they say kind of what I said up front, you get increased ROSC and increased survival, but not neurologic benefit. But this is really key. This is what I think it was eye-opening to me again, is administration of epinephrine if the patient is shockable after initial defibrillation attempts, plural. Now, this comes with a low class of quality of evidence, but nonetheless, this is just, it's a little bit overwhelming, but the quality of evidence for that statement, which I'll show up again here, is epinephrine after initial dose of defibrillation attempts is class 2B, which is weak data. But nonetheless, it is stated. I'm going to go quickly over 2 randomized control studies and then 2 bigger, like meta-analysis type studies. I don't want to go too much into detail. These studies are really get very involved. But this 2011 study from Jacobs goes to show that epinephrine did have a slight improvement of patients admitted to the hospital and obtaining ROSC. But you see here that the numbers of actual survivors are really quite low, 5 and 9 in the 2 different groups. So I think hard to draw firm conclusions. And then the UK had a fairly large study, over 8,000 patients, also randomized, a Paramedic 2 trial in 2018 that showed sort of similarly that there's a 30-day survival benefit, but if you are severely neurologically impaired, it was true that you were more likely to have received epinephrine, and again failed to show the truly important outcome of a neurologically intact survival. So systematic reviews, I'll briefly talk about 2. This one from 2015. I think, you know, these 4 articles, the 2 RCTs and these 2 systematic reviews, are sort of the cornerstone articles that are cited with this body of data, to my research and understanding. But again, this RCT, which looked back at over 500,000 people, some of which are included in multiple studies because they look at multiple RCTs. Again, showing no difference in 1-month survival, and neurologic outcomes worse in the epinephrine group. And the other systematic review from 2014, this was actually a little bit more complicated because they compared both epinephrine to vasopressin and high and standard dose epinephrine, but again, no difference in survival to discharge or good neurologic outcome seen in this big study. And again, it gets a little muddy because there's a combination of comparisons, not just epi to no epi. So I thought it was kind of curious to look around where else in the world, what other people are doing with epinephrine. Japan, I actually could not find I don't know if there's like a nationwide guideline in Japan, but most of the information I could find on Japan's approach to epinephrine have to do with really massive observational non-randomized data. They've put out a ton of ton of papers come out of Japan with very large data sets, and they basically go back and trudge through data of over 250,000 out-of-hospital cardiac arrests, and another study with over 400,000 They do point out that epinephrine is favored over airway as like a first maneuver. I thought that was kind of interesting. That's not something I feel like we have a lot of attention to here. Again, a large, again, this is an observational study, but showing that increased ROSC, but not a good functional outcome. As Veer pointed out, the ILCOR is relied on by Europe. I'm actually in France, in Paris right now, and I intend to speak with some of the EMS personnel I'll be meeting with tomorrow, but on this subject. But in Europe, the European Resuscitation Council, in coordination with ILCOR, suggests that they really do distinguish these two things, shockable versus non-shockable. And for non-shockable, they say, yes, give epinephrine, give it early, as soon as you can. And for shockable, they don't advise adrenaline being used or epinephrine being used until after the third shock. And again, that sort of harkens back to what I was pointing out with the AHA, which I don't think is, again, reflected well in our county protocols. They also point out that don't use an IO unless the IV has failed. And in other words, for attempt IV access first. And then they just sort of say adrenaline 1 milligram every 3 to 5 minutes, like we say, while ALS continues with no particular cap. And my previous discussions with the people, at least here in France, is that they do cap it at 3 milligrams, but that's not Europe-wide. Australia and New Zealand, similarly, for shockable rhythms, they really only recommend epinephrine be given after the second shock. Otherwise, their sort of guidelines fall into line with the others. Canada is doing an interesting, very large 6-year study to try to determine what is the appropriate or maybe like ceiling dose of epinephrine. And they're comparing a standard versus lower dose, sort of a max of 2 milligrams. And we don't have that information yet, nor have I been able to see data put out from this. But this is a great idea, and I think this is really going to have a big impact when it does get released in a few more years. Getting back to the idea of not giving epinephrine until you've had 2 shocks makes me, this is sort of a shameless plug for the San Diego Resuscitation Consortium, but like, gosh, it makes me think, like, if you're not going to give epinephrine until the patient has had 2 shocks and they otherwise would meet criteria for ECMO, then if you're giving ECMO, or I'm sorry, if you're giving epi, you should already be on the pathway of considering, assuming they meet the other criteria, assuming age 18 to 70 and witnessed and bystander and so on. But a refibrillating patient should be considered for ECMO concurrent with consideration for epinephrine. And then just again, my last slide, bottom line, epi is expected to have an increased likelihood of ROSC. It really is recommended, even though there's not a long-term improvement of neurologic recovery. And again, if there's a benefit, it's probably with very early administration with non-shockable PEA rhythms. Again, think of it as a vasopressor, and a defibrillation favored over epinephrine. That's all I have. Thank you.
Thank you very much. And we're going to move right into Dr. Franconi's presentation on mechanical compression devices versus manual CPR.
Thank you. Thanks for having me on. My apologies. All right, so let's get started. And nothing, you can go to the next slide, please. Don't have anything to disclose. Start off, we'll talk about the different devices. What are some of the benefits to both a manual compression or manual CPR versus compression devices? Any disadvantages and advantages of the 2 devices. We'll go into a little bit of a lit review, some current recommendations, and then some final thoughts, okay? All right, next slide. So kind of a little bit of a background here. There is about 350,000 out-of-hospital cardiac deaths per year. Depending on what research you look at, it's anywhere between 10 to 12% of an out-of-hospital survival rate. So pretty low, but not nothing. Some of the factors that kind of play into that is early high quality and uninterrupted CPR. So kind of going back to the basis of just basic BLS. And then early defibrillation, which Dr. Levine just greatly talked about. So what are some of the challenges with this? So in the field, there's a lot of kind of suboptimal things that we don't necessarily have in the hospital setting. Lack of resources. A lot of your teams are 2-people teams. I think you're lucky when you do have a 30-person team. Fatigue, right? So manual compressions, like even normal 2 minutes is a long time, and you can easily fatigue, and lots of times you're doing a lot longer of a transport than 2 minutes. And then upon arrival to an emergency department, there's a lot of different competing tasks, and also while like in the back of an EMS, so you have the airway, you're doing compressions, there's a lot of stuff that's going on. And then you're just in a vehicle that's moving, and whether it's moving, relatively fast, those can kind of play a big part in the thought behind having some kind of compression devices. All right, so next slide for me, please. So we have 2 different devices. Well, there's actually multiple, but the 2 main devices are the Lucas. I think a lot of people I see now have a Lucas 3 and the Zoll Autopulse. Both devices came out in the early 2000s or so. The Lucas is a piston device. It's mounted on that circumferential frame, which you see, and then there's a power source that moves up and down forcefully, stimulating compressions. The Autopulse is more load distributing. So essentially what happens is that band lengthens and then it shortens to be able to combine that to get that compression. The Lucas is what we call more of like both a direct cardiac pump and a thoracic pump, whereas the Autopulse is more like a thoracic pump, meaning so with the thought is the intervascular pressure just increases, which ultimately causes that pumping of the heart. So the Lucas does a little bit more direct, but with that compression around the body, you also have that thoracic pump. So we'll go over eventually some clinical trials. There's, pluses and minuses of using them versus not using them. And a lot of this is based on also using them properly, which we'll get into a little bit in a few slides. All right, so on the next slide, we're talking about some of the advantages. So in manual compression, there's really no special equipment that you need. Training is pretty widely available. A lot of people can train on basic BLS. You can use it anywhere, any scene, whether you have, a small tiny space or, a large scene that you're at, and can use it in an ambulance. And then studies do show that early manual CPR is effective and increases survival outcomes when performed properly. Compression devices, they deliver a more uniform compression depth and rate, regardless of rescuer fatigue. So you kind of eliminate that. They improve the quality of chest compressions, especially for prolonged resuscitations. They take over that physical labor and then allow the rescuers to do other things like take the airway if needed or maintain an airway, get the IVs, all of that. When trained properly, they generally can be put on pretty quickly, and then they minimize the interruptions of compressions during transport. But with advantages comes disadvantages, both that we have. So kind of going back, so fatigue is going to be the biggest one with manual compressions. We see people that are constantly doing compressions, and they may start out with some really high quality compressions, but as they continue to go on, the depth shortens and then the rate gets slower, and there is a lot of rescuer fatigue. And with that can actually come injuries. There are some studies that show like MSK injuries in EMS after prolonged compressions. There's also, again, that variability that, you know, basic, even on the training level of the provider, if you're not trained to do really well, or you're new or not feeling well, so many different factors can go into the quality of compressions with a manual compression that the compression devices do eliminate. However, on the other side, with compression devices, cost. A Lucas 3 is around 20,000, 15 to 20,000, depending on where you're looking. The Auto Pulse was seeing about 8,000 to 10,000. So there's a pretty high upfront cost to these, and then you have to have all of your people trained to use them and to use them properly. So they're not always available. Not everyone always has something to use, and depending on the scene and the scenario, there might not be room to be able to apply one of these devices. So then that kind of adds in some interruptions into your compressions by you're compressing and then you're trying to put on a device. It does, with that specialized training. I'm not sure how much you guys do training on them, but I will say, you know, again, a lot of these studies say, you know, proper placement. I have definitely seen some very questionable placements of usually a Lucas device when they come into the emergency department. So it's very dependent on the user. And then, you know, getting all of your people spun up and being comfortable using them and putting them on quickly. So we're going to go over some evidence supporting manual compression. So this first paper in Go et al. Is a randomized control study that showed high quality chest compressions significantly increased the likelihood of survival in survival to hospital discharge, and did improve neurological outcomes compared to what they call standard chest compression. So I would like to argue that we should always be doing high quality chest compressions, but again, that kind of goes into that user training and fatigue. And then the second, the Hertz et al., which again is a little bit of an older paper, but it had about 30,000 participants of an out-of-hospital arrest. This was performed in Sweden from 1990 to 2011. So it's, again, a little bit older. But they did show that early high-quality chest compressions were associated with better survival outcomes, especially when started within the first few minutes of a resuscitation. So none of this is very new to us, right? It's kind of what we've always been taught about CPR, is the earlier the better. If we can get it in high quality CPR, and you know, the out of hospital bystander versus EMS is more favorable in their outcomes. And then some evidence kind of supporting the chest compressions. This first article took a look at the Lucas device. It was randomized either for a manual compression or the Lucas device. There was no difference in mortality benefit or neurological outcome. However, they did show a more consistent chest compressions, and it was overall preferred for longer transport time. The second, the Donahue et al. Was an auto pulse. In this, it was a retrospective analysis for out-of-hospital cardiac arrest cases where compared survival rates, neurological outcomes, and they found that the use of the compression device, specifically the auto pulse, had similar and even in some cases slightly improved survival rates than manual chest compressions. There was no difference in neurological outcomes. So kind of going back to, you know, does it really make a difference? Questionable, but they were able to receive ROSC slightly more in using the chest compressions. Again, it had more consistent compressions and depth, and it was more beneficial in maintaining that high quality CPR that we talk about over a longer period of time. So actually right now, current AHA guidelines actually still recommend the use of a mechanical chest compression device in a prolonged transport scenario. So looking to continue to use this. So here is just an interesting article that I wanted to bring up because I think a lot of the times we hear that there's probably more traumatic injuries that come following the mechanical devices versus manual chest compressions. So this was a study that had 107 patients, 45 manual chest compressions versus 62 with a piston base. They did use the Lucas. It was conducted in 2018 through 2019. They did not show any difference in the rate of ROSC, major complications, which they characterized as rib or sternal fracture, pneumothorax, hemothorax, lung parenchymal damage, or major bleeding. Now, again, this is in the context that it was properly placed. They have seen, there was like some mention in the article about improperly placed devices that do have a little bit of a higher injury pattern. The next one we are talking about, this was a pretty large study. It was a meta-analysis using 6 random control trials, 2 cluster random controls, and 5 retrospective case controls with 2 phase prospective cohorts. So pretty large study. It had almost 19,000 patients encompassing in this 15 study meta-analysis. That ultimately showed there was no difference in the rate of ROSC between the two. Now, I don't have a slide on this, but I did want to mention there was one study, and I could only find one study that actually compared the 2 devices to each other and not to manual compressions. And I apologize, I should have made a slide on this. So it had both the Lucas and the Auto pulse compared to each other, and which one, if there was any kind of superiority. It did show that the Lucas was found to be more effective and consistent with their chest compressions compared to the Auto pulse, especially for patients of larger body size and those requiring prolonged resuscitation. The Lucas was also favored for neurological outcome, which is big because most of these studies don't have anybody, either device or manual compression, favoring in neurological outcome. But a Lucas was favored for neurological outcome. Now, so overall, like the study did recommend a Lucas if available, but basically said either is good if you have access to them, particularly in a prolonged transport scenario. And then, so kind of, you know, what do we do and where do we go and what are the current recommendations at this point? So immediate response, manual CPR. If you have no compression devices available, obviously always high quality immediate CPR, and then that continuous evaluation. Your rescuers should still be, you know, trained. We do obviously have those BLS trainings that we need to hit, but making sure that we're doing high quality CPR at all times. Compression devices are favored for prolonged CPR transport situation. And then also with smaller teams where fatigue or it's a one-man team in the back, where there's also competing things that we have to do. But overall, they recommend actually a kind of combination of both manual CPR until you're able to get a compression device on, and then using the compression device until transport. So some kind of final thoughts on this is there are some significant advantages of both. Continue to use the compression devices. That's still what is recommended. There is better consistency and fatigue reduction. But overall, it doesn't actually make much of a difference in terms of cardiac output. All right, so here are some of my references, and I will take any questions. I see there's a lot going on in the chat.
Thank you so much to you and all the presenters. A fantastic job. I'm going to pick up the comments and questions in the chat first, and then we'll open it up for further discussion. So starting with Dr. Klein's, I don't know if that was a promotion or a demotion. Captain Klein's points out that having a prohibition of using naloxone can put the paramedics on scene in an awkward place if the base hospital physician is ordering naloxone. So we will agree, and we will take that under advisement as we proceed. And he also talks about remembering giving the 10 milligrams, 1 to 1,000 epi in codes. Yes, those were the days. And then we have Jan Roderick talking about, obviously our focus is on the patient during resuscitation, but what about impact on post-ROSC life sharing in patients who don't have a good neurologic recovery? I actually had the same question. Does anybody want to take that from the presenters? What about organ donation as a possibility?
That's an interesting question and concept that revolves around all of cardiac resuscitation. I have an interest in that concept, and I think the U.S. is a step away from where much of the world is with organ donation. But I don't know. That's an interesting question, really.
Thank you, Veer.
Yeah, I agree. I struggle because obviously the primary end goal of all resuscitative efforts is to resuscitate the patient at hand. You can't really make any presumption, for example, that the patient would be interested in being an organ donor or that the family would be willing to do it. And so, if for example, you also can't presume that there's no suffering associated with non-neurologically intact survival. Remember, CPC, we focus on CPC 1 or 2, which is no or mild deficit, but CPC 3 or 4, which is severely disabled or comatose, is not necessarily, you can't ignore that. It's not CPC 1 or 2 or death. There is that category of patients who are severely disabled, and I think it would be hard to assume that patients that are comatose would want to be an organ donor, but similarly, you don't know that a patient would want to be in a persistent vegetative state either.
That's a very, very good points. The next comment in the chat is from Dr. Schwartz. Do you want to comment on that?
You want me to comment on it? I just
Yeah.
Yeah, I think there's some evidence coming out about different vectors for different relation, and I thought an interesting talk in this vein would be something along those lines of either vector changing during the arrest. If the first vector didn't work, change it to the other, or there's some evidence that starting with anterior posterior pad placement may be better.
Thank you. Good points. I like how you said in that vein, because there was another question down later in the chat about wanting more information on the IO versus IV. I was wondering about that as well. Any comments on that from the presenters?
I don't know if Dr. Sloan was asking about, maybe that should be a subject of the next deep dive.
Yeah, I think both of those are great suggestions for future talks. I've definitely been a proponent of vector change after 3 defibrillations, or starting AP, due to some very early bench research that stuck with me early on when I first started sort of investigating this. And so I think that what you will likely see, with the understanding that I think both of those have draft consensus on science treatment recommendations going through right now. I think once those pan out, it's probably a better time to talk about those.
Thank you. And Dr. Scott was wondering about the average off the chest time while putting on the automated compression device. And we got some answers that maybe it's about 30 seconds, but you may actually be doing CPR during some of that 30 seconds, to gives you some idea of the time. And Dr. Colleen, you want to talk to your manual CPR versus short period of time in fixed locations with multiple rescuers versus not comment?
Basically what I read there, that many things depend a lot on circumstances you're in at the moment. And if you're able to just be in one place, you're likely not going to transport the patient. You have multiple personnel on scene, then taking the time to put a mechanical device on, it may or may not be helpful to you. But certainly if you're going to be transporting a patient, compression quality is going to go down an awful lot during the movement to the ambulance, while you're in the ambulance, and standing, trying to do good compressions in a moving ambulance is just begging for workers' compensation injuries, taking the people that we need to be doing the work and making them no longer able to do the work, which is first and foremost terrible for our workforce, and secondarily not great for our economics either, or our ability to serve the public. So at that point, I think those devices make a lot more sense.
Thank you. And that kind of touches on a couple of things I was thinking about when Dr. Franconi presented the paper that the mechanical compression device causes more trauma. I was thinking, well, for the rescuer, trying to do CPR in a moving ambulance probably causes more trauma. And then also we talked about the cost of these devices, but then there's also would be a cost of a workers' comp injury as well. Dr. Vithalani, did you have something before I move down through the chat?
Yeah, sorry, just to touch on the conversation that's been had about placement time. This is something I feel very, very strongly about. You know, obviously we should be working to minimize interruptions in chest compressions across all aspects of CPR. Mechanical compression devices, as has been discussed, have their benefit and you know, the debate over their role. But you know, for example, if it's taking you know, minutes, for example, off the chest to place the device due to, I'll say, historically, lack of choreography, lack of practice, you know, unfamiliarity with the device, there is a lot of downside that can occur with that as well. And so I appreciate the fact that the team out of San Diego Fire Rescue are actually measuring their time and are interspersing their breaks, not, you know, a 30-second prolonged break. But I would challenge the rest of the agencies out there, if you are not measuring your placement time, I would suggest that you know, take just a random sampling of your mechanical compression device placements and see what your time actually is. It might be great. It might be, you know, shocking to you what the actuality is. And if anyone needs support or help with, you know, identifying the cases and measuring the time, I'm more than happy to do so. Just reach out.
Excellent. And while we have you, the next question in the chat is from Dr. Ennis Jackson, talking about the crews are trained quarterly on the Lucas, which improves the time that the device is implied. But what are thoughts on the AP pad placement with the Lucas device? Have any thoughts on that?
Yeah, you know, it's there's always a balance to be had. I've had plenty of circumstances where we are using a mechanical compression device, including a piston-driven device, and using, for example, Zoll's AP, like Zoll's pads in AP configuration with a puck underneath, with the CPR feedback device underneath the piston. There's a lot of you know, recommendations or pros and cons out there as to whether it's okay to do that or not. I've yet to find anything convincing that says that it really shouldn't be. But I don't see a huge downside to it. Again, understanding that the research is evolving on whether AP placement is better than enterolateral placement.
Thank you. And then he also points out that crews are going directly to IO. I've observed that as well, and suggests we might need a memo to reiterate IV attempts first. We'll certainly look at that during the protocol revision. And let's see, we covered that. Complex medical and ethical considerations. Jen Cochran points out that they measured their times, very good, and found time off the chest was decreased with a two-step application process for the Lucas. Okay, did I miss anything in the chat? And does anybody have any questions? Please either raise your hand or just start talking. I have another question for Dr. Franconi on the study you cited about the Lucas versus the Autopulse. Did you notice where the funding came from that study? Was it sponsored by the manufacturers by any chance?
I will need to get back to you on that. I did not take notice, but I have the article right here. So just give me a minute and I'll get back to you on that.
Sounds good. Other questions or comments?
Best hour of the day. Thank you all.
Thank you so much for joining us. Do you want to give a little bit of background on where you're coming from?
I'm AJ Singh. I'm the medical director of one of the smallest, poorest Central Valley counties, and you can use any guidance and thoughts in the works that you do. It's an excellent work. And I wanted to say to Veer, Vithalani, naloxone risk, the first one, the opportunity loss is the biggest risk rather than cost. And the cost of naloxone and ease of giving, 2 years old should be doing that.
Sure, I agree. I guess I'm using the sort of more formal term opportunity cost to represent the things that are lost, the opportunities that are lost within the overall patient care. Yeah, but yes, the cost is minimal.
I just wanted to pull your leg.
I appreciate it, Dr. Singh. Thank you.
We're very honored that you joined us. Thank you so much.
Oh.
Any other questions or comments? Talking about rhythm and pulse checks for each stage. Yep, that's good.
So actually, that was a great point to look at, which I completely missed when I was reviewing the paper. But Physio Control, who manufactures the Lucas, actually paid for that study. So makes a little bit more sense how the Lucas came out on top of that. So probably something we're gonna, possibly has influenced the results there a little bit. But in the end, they did say either device works great. So I think, the end result of that, but not surprising that the Lucas came on top with at least neurological outcomes.
Thank you for looking that up. Dr. Levine, any final comments?
No, thank you. I mean, it's a unique opportunity for me to realize those two things that I think we can, drill down on with future iterations here, is avoiding epi with a fibrillating patient, at least initially, and then more focus on IV.
Excellent. And again, this whole idea of naloxone in cardiac arrest is going to be discussed by the co-authors of one of the recent papers in 3 weeks at the quarterly state MDAC meeting. So we'll be interested to hear how their analysis compares with ours. And we thank all the presenters very, very much. There was a lot of work to put that together. It was really helpful and will help inform our protocol development as we move along. So thank you so much, everybody. Happy holidays, stay safe, and see you around.